And thanks for everybody.
Meeting is now being recorded.
The focus of today's webinar is about really about maternal depression, which for those familiar with the implicit network understand that that's a major component of what our work is about. In the past year, we've really considered maternal depression in many venues outside of the typical ones that we had previously thought about, for instance, prenatal care, or in the setting of maternal depression screening during well-child visits. And we've thought about maternal depression screening and intervention around maternal depression in the postpartum period or the fourth trimester as well. Really, when we think about it, when you add all those times together, it's really about addressing depression through the life cycle of reproductive health years. And we wanted to think more comprehensively about what those screening recommendations were and how to best address them. So, Maha, are you changing the slides? Or?
Yeah, Maha's driving.
Yeah. Got it. Okay. So a few goals for today's webinar. One is to think about clinical scenarios where we'll use depression screening and what our largest societies say about what the evidence is for screening at those times. We'll look at some of the commonly used validated instruments, including a PHQ-2, PHQ-9, and the Edinburgh. We want to think about why this is done or some of the barriers that impede implementation of depression screening at regular intervals in our practice sites or across our residencies or at our institutions. Think about the prevalence rate for women at different points in time in that reproductive life cycle, and then identify some of the missed opportunities and some of the drivers for persistent maternal depression, and we'll understand why that why that's a significant finding as we talk through some of the most recent data. For today, we're going to talk about the implicit ICC model, which it looks like most of the people that are part of the webinar are familiar with. So we'll mention that briefly, just as a bit of a background. I want to share some of the network data from the most recent R report, specifically around depression, so that we understand where we are as a network and how we're doing with this outcome. We want to think about some of the issues that individuals are facing or that practices are facing with ICC in particular, or in the postpartum period. I do have some background slides related to some of the society recommendations and some new data which suggests that there are long-term effects of maternal depression. And finally, I wanted to talk about some of the effects of the implicit network in terms of leading behavior change and how that might affect the rate of persistent depression for moms and families that we take care of in the future. Everybody should be aware of what the implicit network is. This is a collaborative quality improvement network that was born out of the FMEC and has now been going strong for over a decade. The initial approach was to look at interventions minimizing preterm and low birth weight infants using continuous improvement techniques. The first phase of that work was around prenatal care and trying to do quality improvement projects during the prenatal period. In 2012, that shifted to a model looking at delivering care to mothers who bring their children in for well-child visits and identifying some core risk factors that are known to be associated with preterm birth or low birth weight. And I'll mention that the newest phase of where this network is going is really trying to think about wraparound care in the fourth trimester with the same type of intensity that we think about prenatal care, and with some of the same tools and techniques that we use to sustain clinical change and to implement and overcome barriers at practice sites that we've done in other projects associated with the implicit network. So some of the reason, we'll mostly be talking about the ICC data today, and that's the largest current project that's going on for implicit. And I wanted to review the background and the rationale for why we do that. While we know now that many mothers receive no care at all for themselves in between pregnancies, including no postpartum care or limited postpartum care, and most moms, particularly those at risk, are not seeking preconception care. We do know that those who have children are present at well child visits for their children, particularly in the first few years of life. So it was a known area, an opportunity, a missed opportunity to where women are in the office. It might be the same office where they're getting care. They're an attentive audience. They're willing to receive care and advice from their child's physician or provider, and we use this as an opportunity to implement a screening intervention around 4 topic areas, and we'll talk about what those are, and review specifically the data and the protocols around depression.
So I'm going to take over the next few slides. It's really great, first of all, to be able to talk to you all. I miss you all and wish I could do this more from the West Coast. It's a little bit harder. But anyway, as you guys all know, there are these 4 major areas of our ICC intervention, that all of which were originally framed around associations with the increased risk of low birth weight and preterm birth. And those continue to be a good rationale for including them all together. These include we have different reasons for thinking that they might be related to preterm birth and low birth weight. Smoking, depression, and depression are both related to inflammatory states within the body, and that's the way scientifically people are generally thinking about that being related to preterm birth and low birth weight. And the other 2 have other mechanisms, family planning, birth spacing, or short interconception intervals, and multivitamin folate use have other potential mechanisms, but they all are tied together that way. Depression, of course, that is an important rationale. The more immediate issues that relate to the impact on both the mother and the family and the child, we know that from robust evidence, and we'll review a little bit more about that, that untreated depression is highly impactful on the growth and development, growth in countries where where calories are not so plentiful as they are generally in the U.S., but development everywhere in the child. And it's enough to have the suffering of the mother, of course, to motivate our treatment of depression, but it's also impactful on children. So our model, the ICC depression model, includes the systematic screening of women, and we know from epidemiologic evidence that particularly among vulnerable populations, that the rates of depression prevalence are quite high. It is the most common disorder of pregnancy and postpartum, serious disorder of pregnancy and postpartum. As we see here, 20 to 40% are known in many vulnerable populations to have that. And this overall rate, and again, depends on the study you look at, but overall, you can identify depression at least for a short time, sometime in this perinatal period, which we're thinking of pregnancy in the year postpartum to 2 years postpartum, as being around 40%. So there are a number of different approaches to doing screening. The way that our implicit model, suggests it is potentially using the 2-item screen from the PHQ-9 and then going on to the rest of the PHQ-9 if that screen is positive, and then assessing for safety and severity of symptoms relating, being able to respond to at least assess the severity of risk immediately and by the provider who's doing the screening or is involved with the screening, and not relying on other more more specialized mental health providers in order to do that evaluation, things of that sort. Next slide. So one of the things that is becoming more and more apparent that it's just important for everyone to have on their radar screen is that suicide, turns out, if you include the frame, which now the CDC is pushing and is more states are, through their maternal mortality review boards, are looking into, and this is quite new, only within the last 4 or 5 years has there really been any kind of attention to this. It's clear that it is a major cause of maternal mortality. In some studies, in some states that are digging into this data, they're finding it to be the single most common cause of maternal mortality, which is interesting and important for us to pay attention to. Luckily, it is rare, but it is really important for us to be paying attention to this. Especially as we see the rates of suicidal ideation in the population in the country in general go up, particularly among younger populations, which are going to be coming through and being the majority of patients who will be having kids and growing families. So that is a really critical area for attention. The 9th item of the PHQ-9 and the 10th from the EPDS assess as a screening item, thoughts of self-harm or initially just life is not worth living. And it's critical that we be able to, in our individual clinics, address that, as I was saying, in an efficient manner without disrupting the flow of care, but at the same time, not ignoring that and having that go too quickly. I guess one other thing I'll just mention real quickly is that the suicide rates are primarily from 6 months on. So there's actually a reduction in risk of suicide for women of the same age overall in this period. So pregnancy in the first 6 months of postpartum, less than half of the suicides will occur in that time. A half or more will occur from 6 months on, which really, there's all kinds of potential reasons for that. Women putting off, their desperate feelings until it just overwhelms them. But it also really reinforces the critical nature of this interconception period for screening and treating. And since most women who have depression postpartum already had it in pregnancy, it is critical that screening gets started then, if you're taking care of the same patient. But certainly early in pregnancy and in a continued ongoing way that we monitor this so that we deflect the trajectory towards suicide that happens later. So thanks very much. I think, Mario, you're going to take that back.
Yeah, I think it also highlights that really the time of birth is what starts the interconception period, as we're aware, and recognizing as we think more about 4th trimester and postpartum care that these two periods are overlapped. And when we think about what the network has done and where we have opportunities to make a difference and to impact primary care and maternity care for families, that this is an area of a high overlap for those two things. And as Ian mentioned, it's really the critical time to address maternal depression or risk factors for persistent maternal depression and for suicidality. So trying to figure out ways to augment the care that we're already providing during that period should be a goal of our network. I did want to share a little bit about how we're doing, and this is one thing that people rely on to get a sense of whether or not the ICC model is working. So we're going to go through a couple of slides that share network data across all of the sites that are participating in sharing data in REDCap. So we have 19 different sites, I think, whose data is gone into what we'll share here. And this is data over the last couple of years. Most of this data is phase 2 data, and although many sites had transitioned in July to ICC phase 3, because that's not universal, any data that's captured in the phase 3 period has been down coded to phase 2 results. And so that shouldn't affect the screening rates that we're seeing here, but just to note that we are shifting in terms of the granularity of the data that will be collected moving forward. So as you can see, and what's highlighted below is that both the risk, which means women in this case with a positive PHQ, this is a positive PHQ-9 actually, as well as the intervention rates are variable across sites. And part of that is driven by the N, so sites with smaller numbers of patients overall, or sites that have a lower positive risk might be doing better with the screening or intervention rate, and sites that have a larger population, larger volume, more women that screen positive, it's harder to hit the intervention rate 100%. But I think this data is very promising in terms of the percent intervention for women who are screening positive. The downside of the data here is that there is a lot of non-documentation. And so you can take a look in the the absolute number of women screened, those that have a positive risk demonstrated here, and those that had an opportunity for an intervention. The gap there, where intervention is missing, you see 1763, is really where there isn't documentation about whether or not that was provided. So we have a better job to do in terms of documenting what we're doing. But when we have documented that an intervention was either performed or not performed, seems to be happening over 90% of the time. Just to give,
if I can mention one thing real quick about that data, Mario. Sorry, just to interrupt real quick. One thing to remember also is that given the majority of the populations that we're taking care of, the low screen positive rates that we're seeing are a symptom that normally indicates that we have some improvement to do on how well we're screening also. So it's something to keep thinking about although we've got 90% of folks who are screening positive getting something, there's something happening there. We're probably missing a large proportion of people who, could also have been positive. We minimally expect 10%, and for many of our practices, we'd expect closer to 20% screen positive. So that's, just a reminder that is also something in your PDSA cycles, in your clinics, to consider, how exactly is the delivery of that screening happening.
Because ICC is performed across a 2-year period, we want to get a sense of where this is happening and when we're capturing women. This doesn't show incident data, but does show the prevalent data across women in that 24-month time period. And similar to many of the risk factors that we see, there is a consistency across the first 2 years. And the data on the right is the data that projects to the graph that's on the left, demonstrating that the prevalence rate for depression is somewhere between 6.5% and 9%, really just across the board from the first few months postpartum all the way up until 24 months. And we'll see that there is there tends to be in our data, it shows that there's a little bit of a spike around 12 to 18 months in that time period. I don't know if that projects to national data in any way, or if it is a reflection of the N or the data that's collected, or the quality of the data that's collected across the network. But we do see that there tends to be a peak effect around 12 to 15 months. This data, again, is also network data. You can see the large N representing the number of well child visits. In this case, looking at 72,000 data points that are part of the REDCap database. When all considered, we're looking at about a 7.2% screen positive for maternal depression during well child visits. That represents 10% of all moms who had a screen documented, but we still see that over a quarter of the data is missing, and so there's opportunity for improvement there. When in fact PHQ-2 is positive, we'd like to know if the PHQ-9 is also positive. And so just screening positive for the PHQ-2 alone is not sufficient to really characterize the prevalence or intensity of maternal depression. Looking at the PHQ-9 data, we see that about 42% of moms who screened positive with a PHQ-2 also had a PHQ-9 that we would consider positive in this data set. And that number is, I think, pretty consistent over time in terms of across the implicit network, and consistent with other studies related to the likelihood of having a positive PHQ-9 for moms that screen positive, or for anybody that screens positive using a PHQ-2. And then finally, on the bottom, we can go back one. This is data related not to screening, but whether or not an intervention was in place or provided. And recalling that this is really phase 2 data. So the data that we have that feeds into this scenario is whether or not an intervention was provided without regard to the characteristic of that intervention, the quality or the intensity of the intervention. In phase 3, ICC data collection will have an ability to get more granular in terms of identifying what type of interventions are making a difference. But for right now, this data suggests either an intervention was performed or not performed. And when the depression risk was positive, with a positive PHQ-9, an intervention was performed 87% of the time. And that's of all the data for just the known outcomes when it was documented that something was either performed or not performed, it's actually 92% of the time. So the truth probably lies somewhere in between those two numbers. I just did want to take a minute to, I think on the next screen we'll try to identify a little bit of barriers or challenges that have been present in implementing screening strategies at residency practices. But these were some that, I think that have come out over time, either at our practice or across the network. When we think about how to screen for depression, when to do that, and in what capacity, there are some institutional barriers that make that difficult, including provider time, resources, and in some cases access to mental health services. Certainly, if you're going to screen for depression, you have to have an ability to act on it. And if you're going to screen for suicidality, you have to have the ability to provide services immediately or have an arrangement to refer patients for necessary services. And so those might present a barrier to some practices, hopefully not many, but certainly we all experience a limited access to behavioral health in general. And then as we saw with some of the data, one of the challenges that we do need to overcome is how we get these interventions documented into the chart. Insurance can be a barrier too, as we think about how patients are covered for mental health services and whether that can be part of their practice or integrated within their practice, or whether or not they have separate coverage and where that coverage might be and how they access it. And then we're thinking about, how at a state level payers are paying for maternal depression screening and how institutions are figuring out how to bill for those services and receive payment for those. And certainly some advocacy needs to be done around payment reform for maternal depression screening to make that a more universal part of the payment structure for both pediatric and for maternity care follow-up. So before going on, I just wanted to give a chance to see if any of these things were ringing true at your practice sites and whether or not you've encountered barriers like this or different barriers, and maybe to have a couple examples of how these are being overcome to increase screening or intervention rates across the network.
Hey, this is Lisa. Thanks so much for doing this talk. It's excellent. One of the biggest challenges, and we've done so many PDSA cycles trying to increase our rate of screening depression, because we know for a fact that it doesn't match not only the national rates, but our local rates also. And so we did a focus group with our nurses who do the PHQ-2, and they feel that women are embarrassed and don't answer honestly. And I don't know if anyone else has encountered that. And so we're trying to figure out in our system that is trying to go digital and electronic, if we should be having women in a private space fill out their PHQ-2 and then turn it over if it's positive for a 9, which would be going backwards electronically. But I don't know if somebody else has had any other ideas to increase that rate. We tried just handing them the sticker, which is what we have on our when they first check in, and have the moms fill it out, but it's sort of on a clipboard and it's in front of everybody. So I don't know how private that is, but I'm wondering if that's true, or if Ian's experiences is that given that environment, would moms underestimate their depression?
I'd love to hear others. I mean, stigma is a huge issue in mental health in general. And there's an added stigma related to the perfect mom kind of ideas that most cultures have, that mothers will do anything to take care of their children, and mental health gets in the way of that, so that wouldn't be acceptable within that kind of categorization. So it's a great question. There's no real answers to that. Certainly finding ways to have the exploring ways, and that, I think all of us, this is one thing that's really cool about having a group working on this, is everyone try innovative ways of overcoming these solutions. Just give it a try, see what it does, see how people respond to that. A really nice PDSA where the focus group is great. But then follow it up with like some kind of modification and trial it, and maybe just with a couple of your nurses, in a smaller part of your practice. See if that seems to be making a difference, and then if it's not, then try something else. And there's, as we know now from our ideas about a learning health system, you never stop working on enhancing your services, right? That you stop and you're like a shark and you drown. You just have to keep moving. That is an integral part of our care. So that would be my main suggestion. I really look forward to hearing about people's experiences and ideas.
We can move on, and there might be some time at the end if something becomes part of an area that you want to focus on. But Lisa, I'll share that in our clinical practice, we do the rooming outside of the room and in a public space, and there's only a curtain. And this is not just maternity care or at well child visits, but anybody that's getting a PHQ-2 is a bit out in the open. And now that we're doing that, a larger proportion of the time, I think we're trying to refine that process and try to figure out how to do that in a more accurate and private way. Of course, in this model, in our practice, we have providers really ask moms, and the MAs are not asking moms at well child visits. It's still provider driven in our practice, and so it eliminates some of what you mentioned, but how to automate that like we've done for other things, and doing that in a way where we get the true result and that's patient-centered and private will be important moving forward. Okay, so I just wanted to shift gears a little bit and talk about something which we all know to be the case, and which we signed up to maybe hear and talk more about, but recognizing that as we've made improvements in maternity care, and yet despite better medical care, we see cases of women suffering in the postpartum period, maternal stigma and increasing rates of suicide. We do need to recognize that addressing depression for women who are in their reproductive years is critically important. It's important for them, it's important for their children, it's important for their pregnancies and for the outcomes. It's important for the developmental success of their children and their families as well. And so thinking about, that being really the cornerstone of the family, this is an opportunity for us, those of us that do family health, to really make an important difference. And I think to really make a significant impact in the maternity care crisis that we currently are experiencing. So I want to talk a little bit about kind of who's on board with this and what the recommendations are and kind of where we might be going as a whole in terms of medicine. So ACOG is on board with us. ACOG has come out with a campaign in the last year or two to really emphasize and advertise the rate of depression for pregnant women and women who are postpartum. They recognize that this is, as important as other medical care that women receive. And part of the ACOG recommendations, both for prenatal care and for postpartum care, include screening for depression using a validated tool, as well as screening for other social determinants and social stressors. And so, we're really looking to try to align what they're doing, what we're doing, and really try to figure out the best strategy and time period to implement screening for women along this spectrum. In terms of prevalence, we do understand that the lifetime prevalence for adults in the United States is somewhere around 17 to 19%. Obviously, there's a much greater prevalence than women in the United States. But there is a phenomenon for depression in men and postpartum. Men are experiencing depression at increasing rates as well, which is not necessarily being addressed by what our model is about, but it's certainly something that we are aware and should consider. The annual prevalence for depression is somewhere around 4 to 8% in the United States, and this is probably true for most developed countries as well, with differing rates in the developing world. And so this is something that we definitely have recognized to be the case. We know it to be the case, and we see it really pronounced in the reproductive years. When we think particularly about postpartum depression, point prevalence rates is estimated anywhere from 10 to 20%, but it's really to think about where that depression starts is important. For many of the people that I train and for families that I work with, and for the practices themselves, they're really kind of honing in on postpartum depression as incident depression, but that's not the case for the majority of women. For the majority of women who experience postpartum depression, it's really starting either prior to pregnancy or during pregnancy. And so most part of postpartum depression is not really postpartum, but was really present in the second and third trimester. And so our screening strategies in well woman care and during prenatal care are important in setting the stage for, preparing for postpartum depression and making sure that we're minimizing impact to women and providing maximum opportunities for treatment. For women who do have incidental postpartum depression, the majority starts in the first month. And when you think about the traditional model of postpartum care, where women deliver, are discharged, and then have a visit at their OBGYN provider at 6 weeks, you're really missing the opportunity to capture that, as well as completely missing the opportunity to help and to support women through the period of baby blues, which is generally the first 2 weeks following delivery. As Ian had mentioned earlier, related to suicidality, this is really peaking in the first few months postpartum, but the incidence continues into that first year as well. But most women who develop postpartum depression will have that be present in the first 4 months following delivery, and we'll see some more in the 5 to 12 month period as well. We'll talk a little bit more about the implicit network and some of the data that we have, where we've identified, a similar proportion of women who didn't have depression in the first year, but did screen positive for depression in the second year of their child's life, from 12 to 24 months, and that's an interesting phenomenon as well. The graphic on the side really kind of tries to capture that when you're taking care of women in this period, it's really just a continuum, not really an isolated period of antepartum or postpartum, but really kind of preconception, during pregnancy, postpartum, and in that interconception period as well. You can go, Ma. So why is this important? I think we understand that, maternal depression has an effect on maternity care and directly on the pregnancy. It can affect, nutrition and health status. Obviously, there's a risk for suicidal behavior, both during pregnancy and immediately afterwards. Anhedonia and engagement in things, including medical care, is really important, and not adherence to the things that we've suggested, as simple as prenatal vitamins, but maybe as much as cognitive behavioral therapy or important medications for organic medical conditions. All of that stuff could be, affected in moms who are suffering and experiencing depression or depression symptoms, even if it's not been diagnosed. We recognize that there's good data to support that depression could have negative effects on neonates. It can affect pregnancies and pregnancy outcomes, including preterm birth. It can increase the rate of operative delivery, and moms who are depressed have a higher discontinuation of breastfeeding. What's new and interesting and I think needs to be updated across the network is that there's other developmental milestones and achievements that are affected in families who are affected with maternal depression. And that includes infant mortality or the prevalence of SIDS in the home, physical health problems for child as they grow, other neurofunctioning or cognitive development. And we'll see some data that this is, can perhaps affect children even into their teen years and can affect the mental health of the offspring for moms who are suffering from persistent maternal depression. And so really across the life cycle, this is a chance to intervene when it comes to mental health and families. This is a paper that some of you have heard or seen. It's really just about a year or two old now, from NETSI, that was published in JAMA Psychiatry. They looked at persistent maternal depression. So moms that screened positive for depression really in the first 6 months, and then also I think at 2 points in the first 8 months of following delivery. And they followed these moms as well as the offspring for a substantial period of time. So we really have some prospective data from this project, and I think that's why the results are really transformative for me in terms of thinking about the effect of maternal depression on family health. So they identified that maternal depression increased the risk for behavioral disturbance in children, whether that was persistent or not persistent. But the real data is about whether or not those behavioral problems or effects persisted in the children or the offspring of moms affected by depression. And in fact, they were. So it's hard to really hone in on what outcomes or metrics to look at. They did look at behavioral problems and found that they persisted, and there was an increased association with those even at age 3.5. They identified lower math grades and overall school performance at age 16. And there was a higher prevalence of depression in the children of mothers who were affected by persistent maternal depression, even at age 18. Moms who had persistent depression also were more likely to have ongoing depression as well. So this data, is substantial, but it, needs to be resolved in the larger context and understand other factors that contribute to, neurocognitive development and overall family health as well, but certainly supports increased intervention for moms and families that are suffering with maternal depression.
Yeah, and if I can just add a couple things to that, this was controlling for a genetic, increased risk. So that increased risk is on top of this kind of familial increased risk for depression. So, that sometimes people think about, well, it's because of a genetic issue, but that is considered and controlled for there.
You go ahead, Maha. We mentioned that most of our societies that we rely on are on board with maternal depression screening, and most of us understand this and practice this. ACOG certainly supports this in their bulletin in 2015. We'll see that they recommended doing this in the postpartum period as well. That was a reaffirmation. using any tool that we feel is appropriate. The AASP recommends screening just generally for adults, including pregnant postpartum women. The American Academy of Pediatrics, really about 10 years ago, recommended doing an Edinburgh well child visits at 1, 2, 4, and 6 months, which is as we understand is not well implemented. The American College of Preventive Medicine recommends that we do this, and so does the U.S. Preventive Services Task Force. Go ahead. This is just mostly for reference, but this is the ACOG's committee opinion from 2015 about screening for depression at least once in the prenatal period. That's about as far as they would go, using whatever validated tool that was appropriate and worked with office workflows. Go ahead. This is the 2018 opinion, and really kind of what set the stage for us to think about a larger kind of fourth trimester project about how we can really revolutionize the postpartum period and think about it not as a single point in time, but really as a spectrum of care that focuses on the dyad, including addressing kind of psychosocial factors and well-being for mothers. This is a 2010 publication from the American Academy of Pediatrics, which recommends maternal depression screening at well child visits at those intervals in the first few months following birth. And the U.S. Preventive Services Task Force, which makes general recommendations about screening for depression in adults, but has a specific recommendation around pregnancy in terms of using a validated screen for women during pregnancy as well as postpartum. And of course, our own American Academy of Family Physicians recommends that we screen in general, and that we should at least screen once during the perinatal period, which is consistent with the ACOG recommendation.
I'm going to take over. Is this where you wanted me to start,
yeah,
Mario?
This is great, Ian. Yeah.
Okay. So just Mario, is this data from our own network or from elsewhere?
No, this is just the literature.
Yeah. So just to review, because it is, there are a lot of screening instruments out there, and a lot of different folks, like the pediatricians, of course, are looking to their own, and the obstetricians are looking to their own specialty recommendations for picking a tool. One of the things that, of course, as providers of women in and out of pregnancy and through their life course, it is critical to be consistent, to reduce the opportunity to be confusing about the instruments that are being used. And so for that reason, I've always been really interested in seeing how well the PHQs do as compared to the Edinburgh, which was developed at a time when we didn't know and assumed that the symptoms of pregnancy and postpartum, actually postpartum, because it was originally designed for the 6 weeks postpartum for use in that period, when now quite a long time ago. And there are, it's important to see here that in fact the PHQ-2 and PHQ-9 perform quite well, and arguably in some studies overall better as a screening tool. But I would argue for the fact that they are equivalent, in fact for sensitivity and specificity, the overwhelming evidence is that these are just as good as each other at identifying women with depression. There are some who argue that the EPDS may do a little bit better about anxiety, which is definitely something to consider and something to keep talking about. But the other reasons to use the PHQ-9 is the high volume of evidence related to not just screening, but monitoring progress. So the Edinburgh has never been assessed for its ability to monitor improvement in symptoms, whereas the PHQ-9 is very well established as a target for monitoring people as they go forward with treatments to improve. So for all of those reasons, I think if there's a choice, then it's more efficient to go for the PHQ-2 and PHQ-9, and if you're going to do the PHQ-2, I think you should do PHQ-9 as part of it. But the EPDS is certainly fine to do as a screener, Once you start treating, you should use the PHQ-9 though. Next slide. You know, there are a bunch of different things, and this is data from our work, just showing that in fact, you know, if you're thinking about whether or not the using a PHQ-2 would make it more effective for you to actually implement and sustain, then there's we've shown as using implicit data, and that's consistent with what other people have done as well. That the PHQ-2 works well as a initial pre-screen. Your likelihood of missing people who will end up being positive is very low. There are plenty of people who just use the PHQ-9 though for reasons of reimbursement for screening, and that depends on your particular insurance climate. Next screen. So you know this is Mario, is this these slides are those that you want me to cover?
Well, we just wanted to reinforce that the really the cycle of you know, entering into and out of pregnancy and what we would consider the interconception care period are really really just part of a spectrum, and whether you use the Edinburgh or the PHQ-2 or 9, or what your workflow is, thinking about women being somewhere in the spectrum is super important to recognize both the risk factors that might contribute to depressive symptomatology, as well as the prevalence and increased rate of depression or those symptoms for women who are experiencing really any part of the pathway along this period. And so, you know, as we think about kind of stepping back away from just pregnancy care or just fourth trimester care or just interconception care, thinking about holistic care for women kind of really across the spectrum, I think it's super important to, you know, consider that this is really a long period of time. Go ahead.
Great.
Go
ahead,
there are
Mario.
Some, there are some, you know, I think want to kind of bridge into what some of our data has shown in the interconception care period in terms of maternal depression screening, but also what our work has, you know, really shown in kind of this postpartum period, or what we would consider, you know, the interconception care period, really extending all the way from the time of delivery until the time of the next birth, or what we focus on is in those first 24 months following the delivery in the ICC model. And so, you know, as you can see, and as everybody on the call is probably aware, you know, that this, you know, the idea of having a validated, you know, depression screen and to implement that and to show that there's feasibility of doing that at well-child visits is really a, you know, a major premise for the work that goes into our ICC model. Go ahead. And then thinking about kind of the data for interconception care, obviously we believe it. We've signed up to do it. We've, you know, been experimenting with this for over 5 years, and we have some really great data to show the work that we've been doing. But you know, we're not alone to recognize that interconception care, which was previously ungoogleable, you know, 5 years ago, was something that nobody is talking about, is now really being discussed as a major time period and as a major strategy from the WHO, the CDC, and from some of the major funders in the NIH, including the NIST. And so, but we're seeing this really all over the place being recognized as an opportunity. This is a study that came out of the Netherlands that looked at follow-up care at well child visits, and kind of in a quasi-experimental approach, women were randomized essentially to either receive an intervention, which is a kind of a battery of depression screening, and a referral if they were positive, versus the routine care that they were getting. And what's interesting about this study is that women who received the screening and were referred to specialty mental health at a separate site had lower rates of maternal depression compared to the control group that got the standard of care, without regard to whether or not they actually arrived and received any of that care that they were referred to. So, there to some degree that this is a question of whether or not the systems that are in place and the processes are, really work. and perhaps the act of screening and recognizing that there's some depressive symptomatology and the conversation that happens at the time of referral are in fact even an intervention. Go ahead. You can go ahead, Ma. And then we recognize, some of our own leaders and colleagues that have worked on the ICC model, within the network, able to publish some of this data about the effectiveness, the feasibility of doing depression screening at well child visits in the first 2 months. And we'd like to share in the last couple of slides whether or not that there's some positive results or what we can derive from the data that we have been collecting over the last few years. Okay. This was a paper that was the STFM paper of the year in 2018 from Sukanya and the rest of the leadership team at Implicit. Okay. And then just to mention that one of the confounding features of women in this period of time and what we would consider the fourth trimester, the beginning of interconception care, is that there's a lot of struggles that women are experiencing in that time, including a recovery from delivery and some changes in hormone levels, which may precipitate postpartum depression or baby blues. Understanding that breastfeeding is one of the most common symptoms or symptoms related to breastfeeding, sore nipples or painful nipples or chapped nipples or pain are one of the most common symptoms that are reported in that time period, and that can affect women's experience with depression or similar symptoms, as well as other support strategies, including access to care and sleep, rest, that may be effectively used as coping strategies for women in that time period. So recognizing that this can be a risk factor as well as a barrier towards effective depression care, but that treatment for depression should continue regardless of whether moms are breastfeeding in this time period, and that we should be aware that most of the strategies that we normally use when we use pharmacotherapy for depression are safe and effective while breastfeeding. And certainly we would think about using SSRIs primarily as a first-line treatment for women who are breastfeeding. So the last couple of slides as we wrap up are really wanted to, and I thank Mike Horst for sharing this data, but this is really trying to get a deeper dive into the ICC data set and looking at what we've done with depression screening for moms that we've been tracking for at least 2 years. And so looking at the entire database of 16,000 mom-baby dyads, representing almost 59,000 well child visits, really tried to kind of hone in on a small sample of moms that have had depression screening at least once in the first year of life, and again in the second year of life when a child was coming in for somewhere between a 12 and 24 month visit, and as you can see that number is much smaller, but we are looking at a pretty sizable sample of over 3,500 mom-child dyads, representing 23,000 well-child visits. I'd like to point out a couple things about this data, and which is really network-wide without controlling for the site that the data was coming from, or without controlling for the exact child's age, since this is really kind of one data point in the first year and one data point in the second year. But when compared to the reference group, which is a negative depression screen at the initial well child visit, moms who do screen positive in the first year of life do have an increased odds of screening positive on a maternal depression screen in year 2, which would be a child of between 12 and 24 months of age. So if they had a positive PHQ-2 that was then confirmed with a positive PHQ-9, and no intervention was performed or documented in the chart, the odds ratio of having depression, a positive depression screen with a PHQ-9 in the second year was 3.32. Interestingly, we see that moms that are in that same situation for whom an intervention was performed, the odds ratio of having depression in the second year was lower, although still higher than the referent group. And although it is lower, it's not statistically lower or statistically significantly lower than that moms that receive no intervention. And there's a lot of reasons that may not be statistically significant, but the data are compelling that there is probably some benefit of offering an intervention for moms in that group. We should recognize that a limitation of our data set is that the intervention rates are exceedingly high. So when we look back, we saw an intervention rate somewhere between 88 and 92%. And so the N in the smaller group, moms who had a positive PHQ-2 confirmed with a PHQ-9 but had no intervention, is actually substantially smaller. So even if we were able to detect a difference, it would be hard to have this study or this data be powered enough to show that difference is statistically significant. Another limitation of this data is that we're really looking at phase 2 data, which shows that an intervention was performed without regard to the quality or the intensity of that intervention. And so we should have some better data at some point in the future when we can look back and look at phase 3 ICC data.
Yeah, and I guess I'd just add one thing. My view of this is that, it's great that we're doing these processes of care, but this is evidence from my perspective that we have room to go, in terms of in trying to reduce it just indicates that the interventions that we're doing, we still have women who are likely to need to be identified again and have interventions continue. So that's the big thing, is that we're not one and done. And that's what's so great about ICC and implicit, is that we are following these women forward. And there's the question about, do we want to implement some kind of procedures to keep them more on the top of our list if they were positive before, rather than waiting for them to screen positive again. And I don't know if anyone in the clinic, in the network, is doing that.
This is another interesting finding that really came from that, and it speaks to, I think, understanding what the prevalence is, and also of depression for moms in the postpartum period, but also recognizing kind of that women are at some point in the spectrum of the life cycle. We did identify that, that there was a small subgroup of women who did not have a positive depression screen in year 1, who screened negative, but did screen positive in year 2. And about 7% of moms who received a depression screen in year 2 did have a positive result there. And so, while there is a focus of both the 4th trimester, the immediate postpartum care, and the higher incidence of postpartum depression in those first few months following delivery, I think we do need to recognize that there's an unmet need. Now, this is data that comes from our model, which is to screen moms at well child visits. But for most moms that are receiving traditional care, they're outside of their maternity care at this point, and really would be hopefully engaged on primary care alone. So I think that this type of data serves as really affirming for our model, which looks at moms and follows them through the first 2 years of life, of their child's life, and would have the ability to identify incident depression even in a lower prevalence situation for moms that didn't seem like they otherwise had risk based on their prior history. Below that, we see a couple of the drivers that might be associated here. Less than a high school education seem to be a driver for persistent depression. Certainly medical assistance compared to private, insurance was probably a driver. Interestingly, white race was, seemed to be a bit associated compared to non-white, but also so was being Hispanic as well. So I think we're just limited by some of the demographic, and maternal demographic limitations that the network is plagued with. But we see some of these things which are really not all that surprising from the network level. And the last thing we did want to share is just this next slide, Maha, which shows kind of this information in a graphical representation, demonstrating kind of what where moms start to screen positive and the likelihood of screening positive in the subsequent year based on kind of how they screened in the first year. So moms that in the first set of bar graphs on the left, moms that screen negative in year 1 were overwhelmingly likely to screen negative in year 2. Moms that had a positive PHQ-2 but no PHQ-9, or their PHQ-9 was negative, there was looks like a 33% of those moms did have some sort of positive, at least a positive PHQ-2 and maybe a positive PHQ-9 in year 2. And moms that we knew had a documented PHQ-9 in year 1, really we're looking at 40% of those moms at least having a PHQ-2 that's positive in year 2. So, this data supports that that there are risks for depression, which are present even after the immediate postpartum period, and really kind of long-term care and supportive intervention strategies should be present, really across the continuum for women in that situation. And I think the implicit network is set up in a way to continue to screen and identify that and provide interventions at multiple time points for families that are in that situation. I think it's probably time that we just end. And if there's any questions, I think we can, hang on the line and answer them. But I think that this data is quite promising in terms of what we're doing as a network and our vision, as well as the opportunity to answer some critical questions, based on the size and data that's available in our network, and that we'll be able to parse out a little bit more about what's working once we have more clarity with the ICC phase 3 data.
Is there anyone who has any questions about what we've been discussing? I know we're over time, so hopefully there are a few people left. Well, Mario, I think that, one thing I know we've been working with folks across the network on turning these results into scholarly products that can help others working in this area head towards other clinics and other primary care sites move towards implementing some of these procedures. That's one thing is, making sure that anyone on the line or in the network who's interested should reach out to, I believe you're leading some of that work anyway, and others are too, to reach out to us so that we can get them involved with that analysis and presentations and, making sure the data gets disseminated to their own sites.
Hey, it's Corey. I just have one. Sorry. Go ahead.
Go ahead.
Hey, I just had one question, and that was in the past, I think we had talked a little bit about, sorry, it's Corey Fogelman from Lancaster. We had talked a little bit in the past about adding other questions or potentially other parameters to the interconception care. I don't know if you guys had talked about that in leadership meetings or so forth. One thing I had thought about recently was I noticed that the AAP fourth trimester screening recommendations included a suggestion that we screen the mother's partner for depression at 6 months. And I wondered if ICC was an opportunity for us to implement that. I know sometimes we have fathers present for the well-child checks, and of course, the provider clicks the no button, mother is not present, and then doesn't do interconception care. And it occurs to me that we could be missing an opportunity there as well.
Yeah, it's a great point, Corey. I mean, we've always, because of the framework around reduced preterm birth and low birth weight, we've focused in on the mom. But I think that each individual member of the network should consider doing some of that work and reporting back, and I think everyone would be really interested in hearing about that.
Great, and thank you guys. I appreciate your going over this data for us. It was very helpful.
And I agree, Corey. It seems like every year somebody is interested in trying to identify a little bit more about, paternal depression and coping strategies, and both from a pediatric, framework as well as from a maternity care support framework. And so I think that there's opportunities there, and we've never, really explored it. But and I'm not sure that we did not discuss modifying the 4 factors in ICC to include any additional things, including that. But I don't disagree that it is something that could be included in kind of the normal templated 6-month well child visit and other AAP recommendations.
Was that Lisa who was chiming in too, or somebody else?
No, this is Maha. I just wanted to see if anybody had any other additional questions.
So I think the fundamental thing is just to go right to the PQ, PHQ-9, if at all possible, or a longer screen so we pick up more people.
There are a lot of clinics. Is that Sukanya?
Yes. Hi, guys.
Hi, Sukanya. There are a lot of folks who are just going to the PHQ-9 because of depending on where they're getting payments for and reimbursements for the screening. Some will require the PHQ-9, and there are also quality metrics that are related to that. So in cases, that's one reason to go to the straight PHQ-9. There's also some evidence that we will be missing some people who have suicidal ideation. If you go there, there is a percentage, and so some folks are doing the PHQ-3, adding the 9th question. And then there's just the issues around workflow. If you're, it might end up being better to have people, especially if they're doing it on a clipboard on their own, and then you're going over it later with a provider or a medical assistant or a nurse, whoever might be doing it. There's a lot of considerations in there. If you wanted to do the PHQ-2, though, there is evidence that is perfectly fine to do. So it's, each site will have to figure out what they want to do with that.
Yeah. Well, we have this whole huddle system, and we have sometimes not co-scheduled, but like I'm precepting, but there's also the FM psych person, and she basically just goes through her list and says, do PHQ-9, 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 PHQ-9. So I don't see why I instead of saying do ICC, I say PHQ-9.
Yeah.
Because the MAs in this practice are very attuned to doing the PHQ-9 a lot.
Right. Once you have a specialty person in there, it's hard for them to know what to do without the PHQ-9. So, if you get a positive PHQ-2, you absolutely, I think you definitely need to follow that up with a PHQ-9 if you're going to actually, dive into treatment. So if you're using the PHQ-2 alone, without a follow-up, then I would say that that would be the least desirable of the different options.
I'm saying she's got them all tuned up to always do a Q9, so I think it may not be hard to just, instead of putting the little ICC reminders, is to go ahead and just say do it.
The problem is that we've already built this into Epic for all of us, but this is Lisa. I just wanted to say that with phase 3, I'm really looking forward to see if that will impact our rates of depression screening, because we've added the question, do you have a history of depression? Because then the workflow changes, because if you have a history of depression, then doing the 9 appears to be the most appropriate, because we're no longer screening, they have a history of depression. And so I think some of the challenges is that the 2Q is negative in someone who's treatment. So that's one of the other reasons why we think maybe our screening is so low. So I'm eager to see over the next year how that reflects our screening rate.
Yeah.
Yeah, I agree that the phase 3 setup is, I think, answers some of the challenges that we've had with what to do with a PHQ-2, where people that do interventions for positive PHQ-2 that didn't ever do a PHQ-9, or they did a PHQ-9 without having a PHQ-2 to start with, and some of those other questions that have been, driven around doing that. And I do think that where we're likely to make a difference is around women that already have depression. There's been always questions about why bother doing screening for women in that situation, and it's we haven't had the ability to document effectively around that.
All right, I have to run. Thank you, guys. Bye.
Thank you so much. Thank you so much, everyone, for attending, and then also a special thank you to Dr. Marco and Dr. Bennett. I will be sending this out to everybody to review and to listen in again. Thank you again so much, guys.
Bye.
Bye.
All right, see ya. Bye.